We have another excellent issue this month, beginning with an article from the New England Journal of Medicine titled Fair Allocation of GLP-1 and Dual GLP-1 GIP Receptor Agonists, published in the New England Journal of Medicine. And joining us will be one of the authors of this article, Govind Prasad. Next, we'll discuss an article from Diabetes Care on medical assistant health coaching for type 2 diabetes in primary care. Then an article on glycemic control and cognitive aging, published in Diabetes Care. Followed by an article on tirzepatide for metabolic dysfunction-associated steatohepatitis with liver fibrosis, published in the New England Journal of Medicine. And finally, an article titled, Is Weight Loss-Induced Muscle Mass Loss Clinically Relevant?, published in JAMA. And to discuss this article will be one of the authors, Samuel Klein. Our first article this month is from the New England Journal of Medicine and is titled Fair Allocation of GLP-1 and Dual GLP-1 GIP Receptor Agonists, a critically important topic. Joining us to discuss this topic and the article is one of the authors, Govind Prasad. Dr. Prasad is an associate professor of law at the University of Denver Strum College of Law. Welcome, Govind.
Thank you so much for having me.
This is a critical topic that I think all of us are thinking about, but can you share with us in a little more detail why you and your co-authors decided to write the article?
Sure. What inspired us to write this was just seeing that there was a real increase in prescribing of these GLP-1 receptor agonists, which are a novel class of drugs for treatment of obesity and diabetes. In fact, since we published the article, you've already seen additional indications for cardiovascular treatment as well for these drugs. And the increase in prescribing has at times outstripped supply of these drugs and was raising important questions about if you have more people who are eligible for and maybe even would in principle qualify to be prescribed the drugs than you have a supply, how to decide which patients, which candidates to prioritize for access to these treatments. And what we were finding was that especially in the US, there often wasn't a real framework being used to decide who among people who might be prescribed the drug should receive it. And these issues also arise in other countries as well, and countries have taken different approaches to allocation.
Yeah, it's so important. We've encountered this topic, I think, most commonly in areas like organ transplant, where there's a very limited supply. But I don't think we often encounter this with a medicine, certainly not in a medicine that has such broad applicability. Can you explain for our audience the ethical framework that fair allocation is based upon?
Sure, yeah. So the framework that we developed comes out of some of our work with respect to actually allocating some other scarce interventions, including scarce medications, actually, to some extent. For instance, during the COVID pandemic, obviously, you saw some scarcity of the COVID antivirals or for medications. But you're right that traditionally or most often, that's associated with these absolutely scarce resources like organs. The framework that we use sort of identifies four core values. So one is seeking to benefit people and reduce harm. So in the context of GLP-1s, that would be reducing harm from the underlying condition being treated, whether that's from diabetes, obesity, cardiovascular issues, or other conditions for which a GLP-1 might be prescribed and which it might treat. The second value is equal moral concern. So recognizing that a benefit has the same fundamental significance, irrespective of factors like, say, the race or religion of the person receiving the benefit. The third value is prioritizing people who are disadvantaged. We think about as people who would be the worst off if they don't end up receiving the intervention. So people who, if they don't receive this intervention, are likely to end up with poor outcomes. And then the last one, which I'm actually not going to talk about the last value, there is the fourth value that we basically say is not relevant to the context of GLP-1 allocation. So, for instance, when you're doing organ transplant, we sometimes say we'll give some priority to people who are prior organ donors. But there's no analogous use of this sort of fourth value of rewarding sort of prior contributions in the case of GLP-1s in the way that there is potentially that value, say, for organs.
That makes sense. It's always helpful to have some rubric that allows us then to make decisions, because otherwise decisions become somewhat arbitrary. So using that rubric, you came up with a tiered prioritization. Can you let us know about what you ended up concluding in terms of those tiers?
Yeah, one thing that so there are a couple of things that we ended up concluding. One, which sort of sits outside the tiers that we think is particularly important, is to not just use a first come, first serve method that could lead to people who are receiving it for just cosmetic purposes, getting it before people who do have real harm that they're facing that a GLP-1 could help to prevent or mitigate. And so in light then of that value, the tiers are primarily based on the severity of illness and what alternative options exist for patients. So the sort of highest priority tier is people that have particularly severe obesity, so the very sort of highest BMIs. And the tier we have over 40. We recognize BMI is imperfect, and you could draw the tiers in different places. The sort of specific number is less important. The thought is more that the greater the severity of someone's condition, that both speaks to how much harm could be prevented and to how poor their prospects would be absent treatment. So people with severe obesity, and then also in the first tier, we put people with severe diabetes that hasn't responded to alternative treatments. Then in the next tier, we put people with somewhat less severe obesity. And then for the tiers below tier one, we actually argue that obesity, there's a compelling case for having some priority to that over diabetes treatment for the reason that there are other diabetes treatments that have substantial efficacy, including these sodium glucose cotransporter inhibitors, SGLT2s, but there's not an analogously efficacious treatment for obesity. And for people who've failed the SGLT2s, it makes sense to put them in tier one. But for tiers 2 and 3, we say look at people with obesity first within that tier. And so the tiers sort of go down then as obesity or severity of A1C, which we use as a proxy for severity of diabetes, decreases. So as condition becomes less severe, the priority becomes lower. And then within each group, we think there's compelling reasons to think about averting potential years of life lost. So if somebody is able to start on at a point where it could avert many potential years of life lost, there's some case for considering that as well. And so we mentioned that as a factor in the tiers.
It's so helpful as a clinician who prescribes these medicines quite often. It strikes me that we've traditionally thought of them as, in essence, binary. Either someone needs them or they don't. If they need them, I wish we had them readily available to prescribe. And as I listen to the ethical framework and the tiered approach, it really does make so much sense. There are some people who are in such dire need of these medicines, for whom these medicines are incredibly life-changing and life-prolonging. And the idea of having some thoughtful prioritization made so much sense. Do you have any other thoughts you'd like to share, and any thoughts how this framework might be used?
So a couple thoughts. I think you really nicely summarized the sort of thinking behind it. Maybe if I were to capture it in one sentence, it would be that priority should go to those patients for whom the treatment, the GLP-1, would make the biggest difference compared to alternatives. And that's the kind of value running through the design of the tiers. The other factor that we talk about that I haven't covered yet in the tiers that I think is useful to think about is that we do think at the same time that we design these tiers, there is some case for prioritizing people who are current users for non-cosmetic purposes, even if they wouldn't be in the highest tier right now. So we wouldn't recommend necessarily, for instance, that if somebody's A1C improves or their obesity decreases, that you would then take them off to put somebody who is more severe on. And I think there are strong practical reasons to be very judicious about reallocating the drugs from current users because of the time lag in weight loss starting, potential for weight regain after cessation. So what we say is there's a presumption that current users should maintain access, but that if you had people who were receiving medications for cosmetic purposes, then it could be appropriate to reallocate because those patients aren't in a group where they're going to be experiencing sort of harm from a weight regain if their need was just cosmetic, or where we are concerned about the time lag in that case. The
Hey,
last thing I would want to, sorry, go ahead. Why don't you ask? And I had one last thing I wanted to emphasize about sort of U.S. and other countries, but go ahead,
Sure.
please.
What I was going to say is, I'm so glad that you mentioned that need to not take the medicine away because clinically nothing can be more frustrating, and we see this happening, than someone on a GLP-1 or a dual agonist who has been successful with weight loss and put a lot of work into it as well. And then an insurance company suddenly saying they don't have the BMI anymore that qualifies them, and taking the medicine away. So I'm glad that you clarified that as a part of this framework.
Yeah, so the last thing I wanted to say, and we emphasize this in the end, is a limitation of our paper, and we have some other work in this area that hopefully will come out soon, is that part of the challenges you're mentioning is that in the US, we have a quite fragmented system where different insurers have different policy restrictions, for instance, on Medicare covering weight loss drugs, which we argue that restrictions should go away. And to some extent, the coverage in Medicare now for cardiovascular indications for these drugs may de facto make the weight loss prohibition less relevant. But the upshot here is really that there are other challenges beyond sort of allocation when there's not enough supply, which is our emphasis here, including challenges related to managing costs within a health insurance plan. And one thing that we are continuing to work on is looking at what policymakers in other countries, what policymakers in US states or large US plans are doing or could do to promote fair access to these medications, and also what could be done on a policy level to try to mitigate costs. So we're thinking about these dimensions having to do with the cost to plans of these drugs, which are quite costly right now per dose as well. So it's not to endorse the sort of background status quo, for instance, of the way that the drugs are priced or the way that they are covered that might lead up to this scarcity. We have other work that we're doing that we hope to have coming out soon that will talk about these topics as well.
Clearly very important. We'll look forward to hearing about that other work as well. Dr. Gavin Prasad, thank you very much for joining us.
Great. Thank you so much. I really appreciated the opportunity.
Our next article is titled Medical Assistant Health Coaching for Type 2 Diabetes in Primary Care Results from a Pragmatic Cluster Randomized Controlled Trial. In this trial, this was a randomized controlled trial that compared medical assistant health coaching with usual care among at-risk adults with type 2 diabetes in two diverse real-world community and primary care environments, a federally qualified health center, and a large nonprofit private insurance-based health system in Scripps Health. There was a total of 600 adults with type 2 diabetes who met one or more of the following criteria in the 90 days prior to enrollment: an A1C greater than 8%, an LDL cholesterol greater than 100, or systolic blood pressure greater than or equal to 140. Participants at the medical assistant coaching clinics received in-person and telephone self-management support from a specially trained MA health coach for 12 months. And then they looked at electronic health records to examine the outcomes. Outcomes showed everyone improved over the year, but the reduction in A1C was significantly greater in the medical assistant coaching group versus the usual care group, with a p-value of 0.002. A significant difference, though, was seen by site, showing that the medical assistant coaches resulted in greater improvements in LDL cholesterol than the usual care in the neighborhood health clinics, but not in the Scripps health clinics. John?
So Neil, I think this is an interesting article. If you think about, how you're going to enact change with regard to patient education, a big part of this is someone to be a trusted member of the healthcare team. So if you think about primary care, 90% of the patients who have type 2 diabetes are receiving their diabetes care at a primary care office. If we go back 30 plus years and look at a primary care office, it was filled with physicians and nurses. And that's who the primary care healthcare team is. If you look at the typical office in 2024, the team is different. We have physicians, but we have nurse practitioners, we might have physician assistants, we might have other people who are working in the offices as part of the primary care team. Probably not as many nurses working in offices, and they have really been replaced by medical office assistants. So this was looked at in clinical diabetes over 12 years ago, not a real world study, but one of the first forays into looking at this. We think about diabetes education. The average person who is delivering primary care doesn't have enough hours in the day to do everything that all the governing bodies are asking us to do for our patients. A diabetic educator would be a luxury, and probably less than 10% of offices would have someone who is a certified diabetes educator. So medical office assistants are this part of our healthcare team. And I think if you ask our patients, they might not necessarily know that this person is a medical office assistant versus whether this person went to nursing school in the context of their working, just as though not all patients would identify that their primary care clinician is not a physician at this point. So things have changed. So our medical office assistants are in a great position based on this kind of trust and part of this trusted healthcare team to be able to make some changes. But the problem with our medical office assistants is they live in a little bit of this gray area. So in nursing, so someone who is an RN, there are all kinds of educational tiers that are built in. People have to get a certain number of CEUs to maintain a nursing license that really aren't the same parallel for someone who is a medical office assistant. And a lot of our healthcare systems don't really have things in place for our medical office assistants. And I think with the EMR being able to remember how often someone gets an A1C or a microalbumin, some of those ticklers are all already built in. So they have the trust, they have some of the information in front of them. We just really need to have some programs that we can really build up these valued members of our primary care team and educate them so they can work at the top of their license and help the patients who trust them already. So our next article is from Diabetes Care, and it looked at glycemic control, cognitive aging, and impairment among diverse Hispanic Latinos. The study of Latino investigation of neurocognitive aging. This is also known as the SOL/INCA trial. So this study was done at Hispanic community health centers in the Bronx, in Chicago, in Miami, and San Diego over a 2-year period of time, 2016 to 2018. It enrolled over 6,300 diverse Hispanic Latinos who were over the age of 50. The primary outcomes were cognitive function, 7-year cognitive decline, and mild cognitive impairment. The primary glycemic measurement was measured from fasting blood samples collected at the very first visit that occurred between 2008 and 2011. The visit one mean age was 56.5 years. The average A1C was 6.12. After covariates were adjusted, a higher A1C was associated with accelerated 7-year global and executive cognitive decline and a higher prevalence of mild cognitive impairment. Neil?
John, there are 2 important take-home points here. 1, Hispanic and Latinos have the highest age-adjusted prevalence of undiagnosed and untreated diabetes in the United States. These disparities of care are not right, are things we have to address and have large consequences, one of which we see in this study with with higher A1Cs leading to increased rates of cognitive dysfunction and mild cognitive impairment. One. Number two, you and I have talked on this podcast a number of times about the relationship between hyperglycemia and dementia, and here we see it again. We know that people with diabetes have a 50 to 100% higher rate of developing dementia than those without diabetes. That higher rate comes from a higher rate of both Alzheimer's disease as well as multi-infarct dementia, with a much higher rate of multi-infarct dementia, another consequence of microvascular disease, long-term effects. We know that when someone has diabetes, better blood sugar control leads to a lower likelihood of cognitive impairment. I believe we saw that in the Accord Mind study. So really the take-home points here are twofold. One, glycemic control is important as a measure of decreasing advancement toward mild cognitive dysfunction and dementia. And two, disparities of care are important, have large consequences, and need to be addressed. Our next article is from the New England Journal of Medicine, titled Tirzepatide for Metabolic Dysfunction Associated Steatohepatitis with Liver Fibrosis. Metabolic dysfunction-associated steatohepatitis, MASH, formerly called NASH, is a potentially progressive liver disease with liver-related complications. The efficacy and safety of tirzepatide was examined in patients with MASH and moderate or severe fibrosis. This was a phase 2 dose-finding, double-blind, randomized, placebo-controlled trial. Participants had biopsy-confirmed MASH and stage F2 or F3 fibrosis, that's moderate or severe fibrosis. Participants were randomly assigned to receive once-weekly sub-Q tirzepatide at usual titration protocols, titrated to target doses of 5, 10, or 15 milligrams versus placebo for 52 weeks. The primary endpoint was resolution of MASH without worsening of fibrosis at 52 weeks. A key secondary endpoint was an improvement, a decrease of at least one fibrosis stage without worsening of MASH. Among 190 participants who had undergone randomization, 157 had liver biopsy results at week 52 that could be evaluated, with missing values imputed under the assumption that they would follow the pattern of results in the placebo group. The percentage of participants who met the criteria for resolution of MASH without worsening of fibrosis was 10% in the placebo group, 44% in the 5 milligram tirzepatide group, 56% in the 10 and 62% in the 15 milligram tirzepatide group. This was a p-value of less than 0.001 for all three comparisons. The percentage of participants who had an improvement of at least one fibrosis stage without worsening of MASH was 30% in the placebo group, 55% in the 5 milligram tirzepatide group, and 51% in both the 10 and 15 milligram tirzepatide groups. The most common adverse events were the expected GI adverse events in the tirzepatide groups. John?
So, Neil, I think that this is exciting overall. When you think about fatty liver, affects about 25% of the US adult population. A small percentage of that, but a significant percentage of that will go on to have MASH, NASH, and can go on to have cirrhosis, liver failure with all the consequences that go with that. We've never really had a treatment. The only treatment we've had to offer patients is weight loss. We have looked at some data that has talked about vitamin E maybe being beneficial, glitazones maybe being beneficial, but nothing that looks like this data with a 50 to 60% decrease. Semaglutide had a trial that did not really have this exciting data. We have to kind of pump the brakes a little bit. Phase 2 clinical trial, less than 200 people. So I don't think this is something that people are doing tomorrow, but I think it is an exciting thing potentially in the future to use our weight loss GLP-1s in this arena to help. If we don't think we have enough dollars to cover everyone who has diabetes, imagine if we're going to try to cover everyone who has fatty liver. But I think one of the things that to me that stands out to think about this article is, the pleiotropic effects of these categories of medicines. So some seem to make sense, right? If we're going to lose a whole lot of weight, someone's arthritis is going to be better, someone's blood pressure is going to be better, someone's blood sugars are going to be in better control, and maybe their fatty liver will be better because they're having weight loss. But I think some of the things that are exciting about these classes of weight loss medicines, we talked earlier in the program talking about cognitive impairment that can go with having higher blood sugars. So having better control of diabetes, things could fall in line. There are studies that came out in 2023 that might have shown a decrease in colon cancer, which is a cancer that might be associated with obesity. So that is very exciting. There are studies about Alzheimer's, as you kind of mentioned before, to be part of that. There was a rat trial that happened in the last couple of years that actually showed a decrease in substance abuse with use of GLP-1. So these are very exciting medicines that will have a ton of uses. And that's not even speaking to all the MACE things and decreasing cardiac outcomes, bad outcomes, decreasing the rate of strokes, also potentially decreasing some kidney disease. So just so exciting about these kind of classes of medicine. The question's going to be is how we're going to parse all of these out for all these very worthy considerations.
Our next article was published in JAMA as a viewpoint, and joining us to discuss this article is Dr. Samuel Klein, who is the Division Chief and William H. Danforth Professor of Medicine and Nutritional Sciences at Washington University School of Medicine in St. Louis. Welcome, Sam.
Thank you, Neil. Pleasure to be here.
Sam, I was excited when I saw this paper, and the title is Weight Loss-Induced Muscle Mass Loss Clinically Relevant? Can you tell us why you and your co-authors decided to undertake writing this viewpoint?
Yes, we decided to review this and bring it more to the public eye because of this recent hype regarding the fear that GLP-1 agonist therapy, which can cause marked weight loss, has potential adverse effects in decreasing muscle mass, which would lead to sarcopenia, frailty, and decreased physical function.
And we've been hearing a lot about that lately. Can you talk about why that might not be as much of an issue as many people have said it might be?
Because the loss of fat-free mass, which, by the way, is composed of about 50% of muscle mass. So fat-free mass and lean body mass is not the same as muscle mass. About 50% or 45% of fat-free mass is muscle mass. And what's being measured in these studies is really lean body mass and fat-free mass, not muscle mass precisely. But the reason why it doesn't seem to be an important problem is because when you lose weight, even though a percentage of that weight loss comes from fat-free mass and muscle mass, the majority comes from fat mass. And so the ratio of the loss of fat mass to fat-free mass or muscle mass is always high. And so that the relationship between your muscle mass and fat-free mass and your body weight actually increases with weight loss. It doesn't decrease. So you have more muscle, more fat-free mass per amount of body weight after you lose weight than before you lose weight. This results actually in an improvement in physical function and reduction in frailty, not an increase in frailty and decrease in physical function. I would just add one more thing, is that the percentages of weight that's lost that comes from fat-free mass, it ranges from about 12% to 44%, depending on what study that you read. Among the GLP-1 agonist studies, it ranged from 25% to 39%. And so one of the studies really suggested there is a large increase in the loss of fat-free mass being 39%. But even in that study, the physical function measured subjectively by SF-36 scores and quality of life scores improved despite the marked increased loss of fat-free mass.
Interesting. Another thing that you had mentioned in the viewpoint was quality of the remaining muscle. Can you talk a little bit about that? Because that's not something that I think most of us are familiar with.
So quality of muscle, it really can represent both the composition of muscle, whether there's a lot of fat inside of muscle cells and fat marbling muscle, and both of those decrease. Fat inside muscle cells and fat around the muscle cells decrease with weight loss. So even though you might have less muscle mass, that quality would improve. The other part of quality is its functional capacity, and that represents its strength, the ability to, move objects, squeeze things as well. And the studies vary that sometimes weight loss might decrease strength, others where it does not affect strength, but it always improves physical function. Weight loss always improves physical function, meaning your ability to walk upstairs, to walk a distance, even your ability to carry out daily life activities seem to improve after weight loss, even in older adults who have a reduced amount of fat-free mass and muscle mass because they're older.
That's interesting. And clearly, for everyone who has obesity, better physical function leads to a improved ability to in turn exercise, which has so many both physical and mental health benefits. Now, one of the concerns that I've often heard is around cycling of weight, that if you're on the medicine for a while, you lose weight, and then either insurance changes or there's a supply issue, you have to come off the medicine, or just people stop taking medicines. We know that. The rate we regain after withdrawing from a GLP-1 is often significant. And it's any of us who have exercised at all know it's hard to gain muscle. Are there particular concerns for people who are cycling like that? And help us put that in perspective.
Yeah, that's also a very important question because most people who start these medications actually don't continue them for a period of a year. And so they are stopped for various reasons and then maybe started up again. And so the question is, if you lose weight and regain weight, is the regain of weight different composition than the weight that you lost, meaning that you gain more fat mass than fat-free mass or muscle mass when you regain weight after weight loss? That's been shown to be the case in people who are lean, who undergo very low calorie diet therapy, like the Minnesota starvation experiment in conscientious objectors, and people who are ill, people who have HIV infection, cancer, tuberculosis. If they're normal weight and lose weight and then regain weight, they tend to increase the weight regain from fat more than muscle mass. This is not the case in people who are obese. At least the data did not support that in people who are obese. And that the composition of the weight you lose is identical to the composition of the weight you regain. In fact, there's a very nice study in The Biggest Loser showing a dramatic amount of weight loss and then, of course, regain after people in The Biggest Loser. And the weight regained was identical to the in composition in terms of fat-free mass and fat mass and the weight lost. So there's no good evidence that obese people who lose and regain have a difference in body composition.
Fascinating. Again, critically important. And it's an area where we're going to continue to learn a lot. We're in the early part of our journey of highly effective weight loss medicines. Everything having been said that you've gone over, as a clinician, I feel that it's still important for us to talk to patients about both preservation of muscle mass and, as we would for someone who, whether or not they're dieting, the importance of both aerobic and resistance exercises. What are the strategies available for us as physicians to talk to our patients about when we talk about skeletal muscle mass preservation?
Also, very good question. And physical activity exercise is critical for both metabolic and physical function, health, and quality of life as well. Physical activity during weight loss improves insulin sensitivity for the same amount of weight loss. So it improves metabolic health, metabolic function. it also attenuates the weight that's lost from muscle mass as well. And so you're functionally better if you lose weight and exercise at the same time, particularly resistance exercise. You'll retain more muscle mass and improve your physical function. So I think physical function, which is often overlooked, or physical activity often overlooked in weight loss therapy because it's difficult to incorporate, is a critical part of the weight loss intervention. And that will improve both metabolic health, physical strength, physical function, and quality of life.
Excellent. The other thing that I've heard of as something that helps is having adequate protein or a high amount of protein in your diet. Can you address that?
So if you have a low protein diet when you lose weight, and you increase the protein intake to a higher protein diet, or even a high protein diet, you'll attenuate the loss of weight from fat-free mass and muscle mass as well, because weight loss does not affect your ability to stimulate protein synthesis from protein intake. So you can cut the loss of fat-free mass or muscle mass in half, but that's a percentage reduction, which turns out into a very small absolute amount of muscle mass or fat-free mass loss. So for example, if you lose 10% of your weight and you increase your dietary protein by twice the amount, which we've done in a previous study, you will reduce the loss of fat-free mass by 50%. But that is equivalent to a 0.7 kilogram loss in fat-free mass. So 700 grams, very, very minimal, and probably have no real impact in terms of physical function and health. In addition, high protein intake might cause insulin resistance. So it may actually have some impairment in your beneficial effect of weight loss on metabolic function. These are the data that are available today. With future studies and more data, this conclusion could change. And so we just have to follow the yellow brick road of data and really and not have a set opinion in advance. But right now, the data do not support an adverse effect of weight loss on muscle mass and function.
Critically important area that we're going to stay on top of, continue to learn more about. For me, the take-home point here is that there may be less concern than I've sometimes heard about loss of muscle mass with highly effective weight loss medicines, and the continued importance of exercise and making sure people have adequate protein intake. Dr. Samuel Klein, thank you so much for joining us.
Thank you, Neil. Pleasure to be with you.
For more information and links to the articles that we discussed in this issue, just go to diabetesjournal.org. Until next month, keep listening
and keep learning.